Welcome to this presentation on stomach acid blockers, which is relevant for many millions of people. There are several options for stomach acid relief. However, this presentation will focus on proton pump inhibitors, PPIs. You're probably not aware, but PPIs have been shown to be a cause of health concerns in many studies. We'll focus on the impacts of PPIs on the dynamics of the stomach and how that affects the microbiome of both the small and large intestine, and ultimately your health. What does a crocodile, a vulture, and a human all have in common? Stomach acid with a low pH, which means it's very acidic. Supposedly, crocodiles have the strongest stomach acid of any animal, and for a carrion eater like the vulture, it's also quite strong. But the pH of the human stomach acid is not much higher or weaker than those two. Depending on the reference, the pH is 1.5 to 2. Strong stomach acid makes sense for the crocodile and the vulture, as their food is loaded with pathogens. Stomach acid plays a number of roles, one of which is that of killing these potential ingested pathogens. These animals survive and thrive by eating all parts of other dead animals, the very sight of which would cause us to vomit. Now imagine if we gave these animals drugs to block their stomach acid production. How well would they do? There are a number of conditions where PPIs are warranted. They are indicated for the treatment of a variety of conditions, including duodenal ulcers, gastric ulcers, erosive esophagitis, gastroesophageal reflux disorder, or GERD, and H. pylori eradication. The point of this webinar is not to contradict your doctor's advice. The point is to educate you. You should also know that PPIs are overprescribed by doctors and over-self-prescribed by individuals, which is made easy since several are available over the counter. And many studies have shown them to be detrimental to health via several mechanisms. PPIs have been associated with an increased risk of a number of adverse effects, including C. difficile infections, community-acquired pneumonia, vitamin B12 deficiency, kidney disease, dementia, and osteoporotic-related fractures. In fact, speaking of osteoporotic-related fractures, the U.S. FDA issued safety warnings in regard to PPIs for the potential increased risk of osteoporosis-related fractures back in 2010. You see, stomach acid is necessary to help extract and ionize calcium from our foods, making it more available for our bodies, hence the connection to bone health. This and other non-digestive concerns are listed here on this slide. Since I am the microbiome expert, and I seem to have a one-track mind, we're going to only focus on the gastrointestinal impact. The rampant use and overuse is having a significant impact on our overall health. When I say rampant overuse, do I have proof for that statement? Yes, I do. In a U.S. study estimating the prevalence of ambulatory care visits in which patients used PPIs, it was found that the majority of cases indicated questionable PPI use, with 63% of patients having no documented gastrointestinal complaints, gastrointestinal diagnoses, or concomitant high-risk medications necessitating the use of a PPI. And overuse doesn't only take the form of a number of individual prescriptions, but also duration of use. Individuals still frequently remain on PPIs long-term, clinically defined as more than 8 weeks, even though in most cases, the intended duration of PPI use is only up to 8 weeks. The long-term use of PPIs is especially concerning due to numerous possible adverse side effects. So then why are PPIs so bad for the GI tract to justify this long list of concerns? Let's start with what the drug does. It stops HCl, stomach acid production, in a key step, and it does this very well for many hours. As we said, the pH in a healthy human stomach is about 1.5 to 2, which is quite acidic. Now, gastric acid at a pH of less than 4 has a powerful bactericidal effect, capable of killing exogenous, from the outside environment, acid-sensitive bacteria introduced into the stomach, usually within 15 minutes. However, any increase in the gastric pH above 4 causes a state of hypochondria and potentially increases the susceptibility to various microbes, allowing at least 50% of ingested bacteria to survive the gastric acid. From the therapeutic angle, for peptic ulcers, the target threshold is a pH of greater than 3, and for GERD, the threshold is greater than 4, as these pH strongly correlate with healing of these conditions. But wait a second. We just said that a pH of greater than 4 is also observed to be a watershed line for acquisition of various enteric infections. And studies in healthy volunteers show that PPIs result in a 24-hour intragastric pH ranging from 4 to 6.1. That's way above the threshold. PPIs have also been shown to retard gastrointestinal motility, delay gastric emptying rate, and decrease gastric mucus viscosity, all of which may have direct effects on gut microflora and survival of enteric pathogens. But the effects of PPIs don't end with their permissive effects on ingested pathogens. An increased pH in the stomach also allows bacteria from the nose and mouth to make their way to the lower GI tract. Bacteria from the mouth, in particular, can be troublesome, especially in, say, colorectal cancer, where a number of oral bacteria are highly implicated. Whenever I see an abundance of oral microbiota in fecal samples, I know that the normal checks and balances within the GI tract are not functioning. Beyond this, the reduction in HCl inhibits proper protein digestion and absorption, leaving more amino acids in the colon to be fermented than should otherwise be the case. And guess which bacteria, in general, like to ferment peptides and amino acids? The bad guys. And it becomes more of a downward spiral, as this fermentation leads to a more basic or higher pH environment in the colon, which is a pH that favors bad actors and inhibits the health promoters. All this can lead to small intestinal bacterial overgrowth and dysbiosis in the distal small intestine and in the large intestine. This dysbiosis is at the root cause of so many health issues. Now let's take a look at some data points. If we look at inflammatory bowel disease, IBD, which is Crohn's disease and ulcerative colitis, we see from this large study using more than 360 hospitals from 26 different healthcare systems across the United States that after adjusting for potential confounding variables, including metabolic syndrome, irritable bowel syndrome, GERD, alcohol abuse, NSAIDs, and smoking, patients using a PPI had a twofold increased risk of developing ulcerative colitis and a 2.79-fold risk for developing Crohn's disease. Both of these diseases have been shown in many studies to have significant dysbiosis. The implication here being that the dysbiosis driven by PPI use played a role in the development of these diseases. To continue with IBD, we see that in this large retrospective cohort analysis of over 46,000 IBD patients, that PPI use was associated with almost twice the rates of IBD-related hospital admissions and almost 1.5 times the rates of surgeries. In other words, in those who already had IBD, the use of PPIs contributed to a worsening of the microbiome in these already microbiome-compromised patients. The authors state that, quote, PPIs have also been shown to reduce anti-inflammatory bacteria such as Faecalibacterium, which could also potentially lead to poor outcomes in patients with IBD. Faecalibacterium is the superhero of the gut, along with a number of other great health promoters which are reduced in IBD, such as Roseburia, Coprococcus, and more. In some of the bad actors, the opportunistic pathogens, they are consistently, significantly shown to be increased in IBD versus healthy controls are Enterococcus, Escherichia, Lactobacillus, Streptococcus, and Veillonella. Keep those names in mind if you can as we look at some studies which analyze fecal microbiome changes in those using PPIs. This study investigated the association between PPI usage and the gut microbiome from fecal samples of 1,827 healthy twins. Among the taxa significantly increased from PPI use, shown here in Figure 3, are three of the genera I just implicated in IBD: Streptococcus, Veillonella, and Lactobacillus. Yes, Lactobacillus, as in the bacteria in your probiotics. Watch my presentations to learn why I'm not a fan of Lactobacillus. As for taxa that were significantly decreased with PPI use, are two families absolutely loaded with health-promoting taxa, Ruminococcaceae and Lachnospiraceae. How about some more proof? I know Figure A is a little difficult to read, so I'll translate. This study examined the association between the PPI usage and the microbiota present in gastric, mucosal, and fecal samples from GERD patients and healthy controls. I'm only going to reference the fecal data. In Figure A in red, we see the significant differences in the fecal microbiomes for GERD patients taking PPIs as compared to the other two groups. Among other taxa, Bayonella and Streptococcus, our usual suspects, are listed. Also listed are common members of the oral microbiome like the genus Rothia and family Micrococcaceae, highlighting the permissive passage of bacteria to the stomach as we discussed earlier. Here we have a study which used PCR technology, which, if you've been watching my webinars, limits the scope of the findings, as they only can use primers to target and on pre-selected suspects. Even with this limited technology, we see the same theme, with significant increases at 4 and 8 weeks for a number of species within Lactobacillus, as well as the genus Streptococcus, once again, which by the way is also a genus present in the oral microbiome. Additionally, another troublesome genus, Staphylococcus, was significantly increased. Also increased at 8 weeks is the last family you want to see elevated, Enterobacteriaceae, which is a family loaded with bad actors to include Escherichia, which is where E. coli comes from, which is also correlated with IBD like the others. Not only these classic opportunistic pathogens correlate with IBD, but with all conditions I've analyzed to one degree or another. This is our last slide looking into the effects of PPI use on altering the microbiome. These authors analyzed the gut microbiome composition of 1,815 individuals, spanning 3 cohorts, and summarized the data of all the significantly changed taxa in the last column entitled Meta-Analysis. Red is an increase in PPI use, blue a decrease. Among the oral taxa we keep seeing, a significant increase was shown for the genus Rothia and the family Micrococcaceae. As for the other classic opportunistic pathogens we discussed in IBD, this paper also showed a significant increase in Enterococcus, E. coli, a number of species from Lactobacillus, a number of species from Streptococcus, and several species from Bayonella. There are a number of other papers which reinforce all these findings from our last 4 slides. Now you can see how the risks in IBD are significantly increased during PPI use, as the same bacteria that are problematic in IBD are increased by PPIs. But as I said, these bad actors just aren't detrimental in IBD, but across many conditions. Once you've been exposed to my webinars and you begin to see these same players repeatedly, you'll realize how detrimental PPIs are to the microbiome. One of the frequently mentioned PPI-induced health concerns is that of enteric infection. This very large study investigated the association between gastric acid suppressive drug use and the occurrence of enteric infection. These researchers found that the risk of an enteric infection using PPIs was over 5.5 times that if compared to healthy controls. The top 3 infections were caused by Enterococcus at 44.8%, C. difficile at 34.5%, and Salmonella species at 10.2%, all shown in Table 5. And you may be surprised to know that they are all or can be a part of the normal microbiota. That's right. You probably have at least one species of Enterococcus in your microbiota right now. You might have at least one species of Salmonella, and for the dreaded C. diff, the rate of colonization varies wildly depending on various factors, but given its omnipresence and hardy nature of the spore, at one point in a year, you'd test positive as well. But these and other normal inhabitants within your microbiome don't wreak havoc on your health so long as the health promoters are present in sufficient quantity, which is a function of environment and substrate, or their fuel. If you recall from the last slide, C. diff was the enteric infection more than 1/3 of the time. A C. diff infection is a bit of a misnomer, as it implies you got infected, when in reality, it can be a normal inhabitant of your gut. It's really a classic example of dysbiosis, just a severe one. The primary cause being antibiotic use, but also the correlation in the data between PPI use and C. diff infection is very strong. Again, the environment is being altered to one which favors bad actors, and C. diff can be one of the worst. I'm not going to cover everything in this comprehensive work, just what's within the rectangle, which is the column for initial C. diff infections. As you can see, antibiotic use was reported as a very common, independent, statistically significant risk factor. Next is recent hospitalization. And what do people often get prescribed in hospitals? Antibiotics. Below that, you see being female, which has less to do with gender and more to do with the fact that in many PPI studies, women are found to use PPIs at much higher levels than men. And last in our box is our topic, PPI use. In fact, the US FDA issued safety warnings for the potential increased risk for C. diff infections associated with PPI therapy back in 2012. And here you can see the dramatic increases in risk for a C. diff infection in children in whom acid suppression was used, along with how recent the exposure was. Now here they lumped H2 blockers with PPIs. However, this gives me the opportunity to point out that in multiple studies, to include this one, the risks of PPIs are much higher than that with H2 blockers, as the PPIs are stronger drugs. At times, I in fact recommend H2 blockers in the beginning if a person is having significant issues in their stomach, because the involvement of histamine due to immune dysfunction is strong in some people. But this is only temporary until the underlying inflammation can be resolved. I don't recommend PPIs at all, since the people I work with almost always have dysbiosis, and as we saw earlier, PPIs are associated with significant worsening of the microbiome. And this PPI-driven dysbiosis increases the risk for C. diff infections, as you've now seen in 2 of many studies I could have chosen. Here is a chart of mine after a meta-analysis of the microbiome in various facets of C. diff. I used 30 human fecal microbiome studies in total. The blue box lists the range of cohorts. This is the microbial signature of C. diff. The orange color indicates an unhealthy association, while green indicates the opposite. As you can see, 4 of our usual suspects, which we saw increased in PPI use, are noted here with orange arrows: Enterococcus, Escherichia, Veillonella, and once again, your probiotic, Lactobacillus, are all highly correlated with C. difficile in one way or another. Whereas in the healthier cohorts from these 30 studies, many of the amazing health-promoting bacteria I've identified over the years were significantly higher. These include one name with which you're probably familiar, Bifidobacterium, which is the other main genus in your probiotics. But other names you've likely never heard of before, such as Allostipes, Eubacterium hallei, Roseburia, Ruminococcus, and Faecalibacterium prausnitzii. As you will learn more from my presentations, these names will become more familiar to you, and you'll appreciate how detrimental PPIs are on the microbiome, which can affect you in many ways, both within and outside of the GI tract. If PPIs are deemed necessary, then at least it's worth considering supporting your microbiome during PPI therapy. Prebiotics have been repeatedly shown to significantly increase the health-promoting bacteria decrease with PPI use. At least in this respect, you can work to offset the environment-altering effects of PPIs by altering the environment yourself in the right direction by providing the very fuels that the good bacteria are able to use. It's important that your regimen contains an intelligently blended and properly dosed set of prebiotics designed to support the microbial signature of PPI use, while also taking into account any symptoms. If you found this presentation informative, I have many more for free in my YouTube channel and also in the Microbiome University tab on my website, themicrobiomeexpert.com. There you can select from a wide variety of topics. And if you or a loved one are struggling with a disease/condition, I have condition-specific presentations as well, along with their microbiome protocols found within its respective tab on my website.